All right, welcome to the Dr. Lexi Show. Today I have a very special guest that everybody knows about anyway. Marybeth Tomory, like amore.
There you go. You got it.
So then we get into World TAPS Day, Twin Anemia Polycythemia Sequence. And I have a personal, I don't want to say love for this, but I'll put the link in there at some point for this too. But I was covering a hospital in Houston, and a patient came in with twins. We knew they were monochorionic diamniotic, so the MODI type, and the ultrasonographer was fantastic. And in their practice, they would do middle cerebral artery Dopplers on all their MODI twins.
Yep.
So they're screening for fetal anemia.
Yep.
Some practices do this, some don't. It was interesting. The patient wasn't due for a growth ultrasound. The ultrasonographer was like, man, when I'm just scanning, one baby's abdomen just looks really small and the other one looks really big. And she's like, she just had a growth 2 weeks ago.
This is what we like our dual screens for.
Yes. And everything was fine.
Yeah.
So when she says dual screen, she was like, you can see both of them at, I don't want to say the same time, but you can
make it so that you have a right comparison.
Compare at the same time, right? This is where for a person who has twins, knowing who's doing your ultrasound, like, are they in a high-risk pregnancy center? Have they scanned twins frequently? It's okay to ask them that.
It's okay.
Because when someone has a comfort, like Marybeth does, you can tell when someone scans with grace and you're like, you've done that a while. And when she looked at the one placenta that they share, one side of the placenta was really thick and bright white.
Yeah.
The other side was teeny tiny thin and almost black.
Yeah.
And you could almost see a line.
Yeah.
It's one placenta, remember, not two different ones.
Yep.
You could almost just see this little delineation of where one baby was feeding off of one side of it and the other off the other side.
Yeah.
And honestly, and very few people have seen this.
I have seen this picture. It's startling.
I'm getting chills. I'm not going to lie.
Yeah, it is amazing. Yeah. And I've never seen that.
No.
Never.
And I was like, oh, wow. Because you read about these things and you're like, very rarely could you see this finding.
Yeah.
And this ultrasonographer was great.
These things, they can happen really fast, which is the reason that we want you to come in every 2 weeks.
Yes.
Because it can really go from totally fine to extreme so quickly.
And very rarely is it like a day.
Yes.
But I mean, those, 2 weeks is, some people are like, oh, that's too frequently for me to come in. But like you said,
things can happen very quickly.
But she was sent, and I'll link the article because they wrote it up. I think the family was very grateful and they were wonderful patients. But we sent her straight to the hospital.
Yeah.
And we put her on their monitor before she left the office. Yeah. And she went straight to the hospital. And I think she delivered within the next 24, 48 hours because on the monitor, they didn't look good. And when you see these babies, when they were born, the one that was the anemic one looked very different than the plethoric one.
I bet.
So when we say,
because I don't think people realize they come out looking totally different.
White and pink.
Yeah.
Literally.
But like
white and pink.
Really white and really pink, like red. I remember seeing that, like, holy cow.
But
I mean, remember, like, we can't see that color on ultrasound.
No.
Like, we have to use tools that we have. We can't see that.
Correct.
But they come out and you're like, holy moly.
So
I think I would see that.
Right. But when we screen with middle cerebral artery Dopplers, for those, blood that is thin, or let me describe that differently. When someone is anemic, blood moves faster.
Okay.
So if the kiddo's anemic, that middle cerebral artery Doppler, the fluid is going faster. That's kind of a, I don't want to say dumbed down way, but like a basic way to
let's
describe
talk about
it.
a very basic way.
Yeah. So it's going faster. And the middle cerebral artery Dopplers for this patient at that time very clearly showed that one baby did not show concern for anemia.
Right.
And the other one clearly showed concern for anemia.
Yeah. And again, you have this great comparison, right? So like some things, sometimes with twins, especially when we're talking Dopplers, for sonographers, you get one MCA looks nice and sharp, and you get the other one that's like muted, and their diastolic is high. You're like, ooh, why do these? And then
they
of
look
course,
different.
We as sonographers like, it must be me, right? It's got to be me. But sometimes it's the baby.
It's the baby.
Like let's look at that. But when you're like talking about that gestational age and monitoring that, and you've got that MCA coming straight, with your angle of incination, it's perfect. And you're sampling and you're looking side by side and they look different. That has to be a thought in your mind. Why does this look different?
Yep.
And that's what we're screening for is anemia with
and
MCA Dopplers.
Tangentially for the ultrasonographers, when you mentioned the angle of
Insination.
I love that term.
Mm-hmm.
When you are doing a middle cerebral artery Doppler,
Yeah.
the things that I love, that I would love you just briefly to touch on, zoom in for me.
Oh, for
as the
love
reading
of
doctor,
God,
please.
yes.
Zoom in.
It really should take up 50% of your screen plus. I mean,
and there are times when I don't even see color, and then there's a Doppler waveform. I'm like, no.
Yeah.
And
this is image optimization, which is really a basic. It should be in all your images. You should be optimizing every image.
So give me a very like if I'm an ultrasonographer and you're telling me, hey, this is what you should do to get a good MCA Doppler. Right. And they're not easy to get.
They're not. They're
very difficult.
They're
to
not.
Get.
Sometimes
babies
they're harder. Babies move. The way I've always been taught is I like to do MCAs first because I like to do it when a baby is very quiet. It's helpful. And so before I really start anything with the babies, I always try to do the MCAs just because I like them quieter. Always optimize your images, meaning zoom in, decrease your depth, narrow your sector image. On your color Doppler, we always want to optimize our color. We want our wall motion filter to be kind of a mid. We're not looking low. We're not looking high. We don't want lots of color and we don't want no color, right? And so the way I was taught to do MCAs is not angle correct at all. And I had a physician tell me, if you cannot get it at 0 degrees, meaning, if your probe is here and that artery is coming up 0 degrees, it's really hard to sample an artery that's going this way, right? So if you can't get it as close to 0 degrees, it's not accurate. So don't do it.
Please say that again. No, I mean, seriously.
But some physicians are fine with angle correcting on MCAs. It personally doesn't make sense to me to angle correct. If I cannot get it as close to 0 degrees, it is not accurate. And I don't think it is fair to have you make clinical decisions that can change the trajectory of what happens in this pregnancy by an incorrect Doppler. So for me, in my practice, if I cannot get it at 0, it's not happening. Like unobtainable for today.
Yeah.
You want them to come back tomorrow? I'll try again tomorrow. Yeah. You want to come back I'll try again a couple hours. But that is as close to 0 degrees as you can. We want it within 2 millimeters off the break of the circle of Willis. And you want your sample gate. You don't want a big sample gate and you don't want a little sit.
But you want it to be.
You want to be just right, but small.
Now, I've always heard,
Smallish.
and correct me because this is what my brain goes with. You want the width of that gate to roughly be the width of the vessel that you can see. Do you agree with that?
Yep.
That's a nice rule of thumb.
Oh, it's beautiful.
Okay.
Yeah.
I like that.
Yeah.
Because I can't stand when this is the vessel and then the gate. Like,
you know what's funny is I've always just done that, but I've never thought about it in that way.
The data says that I've read.
I love it.
The other thing too.
Easy to remember.
Yes. The other thing too is when the Dopplers are abnormal, quote unquote, for a middle cerebral artery, we use the term multiples of the median. And above 1.5 multiples of the median. It's adjusted for the gestational age. It is, if it's elevated and you don't see something else that makes you gravely concerned,
right?
It could also be, like you said, your angle, the baby
is
moving.
Off,
we usually repeat it.
Whenever anything looks now, if I get it, it's really hard to make something abnormal ever look normal. It is really easy to make normal look abnormal. So you kind of have to think, does this look wrong because of something like the position or the angle? So if it looks abnormal, I'm going to take a couple more because then it should always look abnormal.
Exactly.
But if I get a beautiful MCA, it's 0 degrees, I'm not angle correcting, and it's beautiful, I don't need to, I'm good. I know that's what that's supposed to look like. I know the values are normal. I'm okay not doing 6. And I'm sure you as a physician prefers me not to give you 6 more normal Dopplers, right? Yeah. But sometimes you can just still check yourself and not take multiple images. I mean, it's your job to really investigate. Yeah. But if you get a good shot, but if it looks abnormal, take a few more of them. Yeah. Check them out. Can you get a normal one? And this is not a perfect science. I mean, yes, you can get abnormal to look normal. It's, again, we have this variation of, it's not like a light switch. It's like a dimmer switch of how things kind of go bad. So, you might have good, bad, good, bad, bad, good, bad, good. You have a variation.
Yeah. And from a patient side, if you are ever told that the middle cerebral artery Doppler is abnormal, they may repeat it. Don't be nervous that it means that everything's going poorly. Right. They may just need to repeat it because of a lot of those things. Yeah. And,
you get especially later on in pregnancy and, especially those baby A's can pop their head way down in the pelvis. Like they can get hard to see. So, but we really want to do our best and we want to try, but we don't want to make huge altering decisions when we don't have a good sample.
Yeah.
So it's just, I'm really sensitive about that stuff.
Agreed. Okay. All right. So we tackled TAPS, Twin Anemia Polycythemia Sequence.
Yeah. But going back really quick with the belly thing.
Oh, yeah.
A thing that I think is one of the coolest things on TAPS, and I'm such a dork, it's the starry night liver. So when we look at like the abdominal circumference on MODI babies, the liver is really big in pregnancy. So in fetal life, you've got this huge liver that generally is on the right side. It should be, unless you have situs inversus. But the left lobe of the liver actually goes above the fetal stomach. So it really expands when you have that good abdominal circumference. And for patients, this is where they measure how big the belly is on the baby. We see the stomach and the portal sinus and the umbilical vein, but we see a lot of the liver. In TAPS, they have what we call starry night appearance of the liver, but that can kind of make their bellies bigger and then the other one's smaller. I love the little starry night. And I like to compare MODI babies, again, using our dual screen and split screen. And I just do liver shots. I just think it's cool. Like no one has said, I want you to look at every liver side by side, but it's really like, I'm just constantly checking myself. Like, do I have any indication of TAPS? And I think starry liver is like one of the cool. I like that one, I geek out of that stuff, but I really like when you compare your AC biometry, like a transverse AC in a dual screen, you can see those livers side by side. You can see the big and smallness of the belly. But when you look sagittally, like if you're looking at the front of the baby, you can see those full livers. It's so cool. I love it. It's crazy. So you better believe I'm giving you tons of dual screens on those. Love it.
Tell me really quick too, the hashtag or your thing on Instagram and all that jazz.
I am Sono Eyes Ultrasound on Instagram. I mean, I'm technically on TikTok.
Is it the same thing?
I think it's sono.eyes. That's what I'm on TikTok. And of course, I'm on LinkedIn.
Yes.
Things like that. So
all the things.
Yes, all the things. Facebook too. But really my Instagram is where the majority of my content lies.
Well, today we did a lot of discussion about twins. Thank you very much to Marybeth Tomory for all of her help and guidance.
Thank you for having me.
Everything ultrasound related, which is fantastic. And we'll have you back again as long as you'll come back.
Anytime.
We'll make it a regular stop here. But we hope to have expanded your knowledge, developed some skills, and as always, we want to have an impact on you and your pregnancy. I'm Dr. Lexi, wishing you a happy and healthy pregnancy.